All right. Good afternoon, everybody. Just right afternoon here in Providence, Rhode Island. And good morning for those of you who are in Chicago or further west of us, certainly. Or good afternoon and evening to people who are joining us. We actually have people joining us from Asia. And so I know it's a little late at night, but thank you for joining us. My name is Ashish John, the Dean of the School of Public Health at Brown and a professor of health services, policy and practice. And I've been doing a series of these conversations with global leaders in public health. And I am particularly excited today to welcome Dr. Helene Gayle to this conversation. Helene is a physician. She's currently the CEO of the Chicago Community Trust, which is one of the oldest community-based organizations and working on a series of issues around health and equity for years. And before that, was CEO of CARE and has had a very illustrious career at the CDC, at the Gates Foundation, and elsewhere, really driving issues around health and equity, both in the US and around the globe. A native of Buffalo, and we've had a little bit of a chance to talk about her career. One of the things that I've learned over the years is if you look at some of the most distinguished people, their careers often look linear only in retrospect. You can look back and draw the line. And I say this a lot to young people that I try to advise and mentor, that it's rarely so linear and so obvious when you're living it and moving forward. And hopefully we'll have a chance to dig into that a little bit. There are a lot of really interesting parts of the work that Dr. Gayle has done over the years, and I'm excited to get into them. She really has been one of the national and global leaders on issues, not just of health, but issues that are really adjacent to health, that come right up to health and interestingly question where are the boundaries between what does a health person think about and what does a policy person think about more broadly. And I think Helene has really blurred those lines in ways that have been very, very effective. So let me stop just chattering and welcome Dr. Helene Gayle to this conversation. Helene, thank you so much for being here.
Really my pleasure. Great to be with you.
Great. Well, thank you. And I have so many places I want to go, but I want to actually start off, if it's okay with you, at the moment that we're in right now. So here we are in the pandemic. Vaccines are here. Vaccines are rolling out. And we're doing okay. We could be doing better, but we're doing okay. And people are starting to get vaccinated. And that's good. But one of the things that's become really clear just in the last couple of weeks is despite all of the concerns that we had about making sure that we were doing this equitably, already we're starting to see the preliminary data that it's not going so equitably, that there really are differences in how these vaccines are getting rolled out. Among the many things that you've done, you chaired the National Academy's task force on equitable vaccine allocation. Can you talk about, and that was, by the way, I think the first thing in the public sphere by a group of experts that really try to lay out how to think about vaccines and make sure they got out efficiently, but they also got out equitably. Can you talk a little bit about how you all in that committee thought about this issue, what your perception is of how things are going so far, and what we might do moving forward? And let's focus initially just on the US, because then I want to use that as a jumping off point to talk more globally.
Sure, thanks. And lots to unpack there, but obviously such an important issue right now. And when I think about where we were when I got the call from the National Academies to consider co-chairing this, we were in the middle of the summer. We didn't have an approved vaccine, and there were so many unknowns. What we did know was that this was a pandemic that was continuing to evolve. That was disproportionately impacting seniors and disproportionately impacting communities of color. And that no matter what vaccine was developed, that there would be a scarcity in the beginning, and that we had to think about what does it mean to allocate a scarce resource. And so, the National Academies was asked by the CDC and the NIH to provide a blueprint that could be used by other policymakers, particularly the committee that advises CDC, ultimately the ACIP, the committee that really gives recommendations once there is a vaccine. So that was our starting point, and we had a group of incredible people who you know, covered the waterfront of expertise from epidemiology, statistics, bioethics, uh, demography, epidemiology, public health, clinical medicine, et cetera, because it was really important to have all of those kinds of expertise weigh into this. And I think what we tried to do was to start from a values-based and an ethics-based perspective. And so we developed some core ethical principles around maximal benefit to society, given the impact that it had, not just on health, but also on society. Equal regard, because again, the populations that were impacted were not always the populations that had the greatest status in society. So we thought that was important. And that mitigating health inequities, again, because of the impact on disproportionate on communities of color, as well as thinking about, you know, how should this be thought about from an ethics perspective procedurally. So fairness, transparency, and evidence-based at a time when, you know, again, back to that time, there were real questions about whether or not people were thinking about this from a evidence base. So those were, you know, our kind of founding guidelines and principles, if you will. And then again, stepping back before we started thinking about who gets it first, to thinking about where the greatest risks were. And if we could think about the risk of who acquired, who was most at risk for acquiring or transmitting, who was most at risk for getting serious consequences, and who was at risk for negative societal benefits, again, given the health and economic nature of this. That was what went into, and people focus so much on the phases, but I think we felt it was very important that this was grounded in ethical principles and in a risk framework, so that we were really thinking about where could we have the greatest impact at the moment when vaccines became available. In addition to that, we also felt, you know, once we looked at the phases, that there should be a prioritization for populations and geographies that were highest on what CDC calls a social vulnerability index, so that we were really making sure that there was access at the in the communities where the need was greatest, all across the phases. The phases themselves, you know, were not written in stone, but were illustrative of how do you think about all of those risks and go from the people who had the combination of highest risk for those four risks that I described to lowest risk, and that's how the phases were derived. Obviously, you know, we didn't know everything there was to know at the time, but it's been interesting to see that I think those things did stand the test of time and really served as a real framework for how do you think about something this complex when you have scarcity, but you also want to think about the principle of equity. And I'll just close on this point to make the case, make the point that, you know, so often since, you know, in recent times, there's been a lot of debate about speed versus equity. And there's so many people who have said, let's just get as many people vaccinated as possible. Well, as an epidemiologist, you also want to think about where you're going to have the greatest impact and where do you target, because just getting people vaccinated, if you're vaccinating people who have the luxury to stay at home, who aren't going to acquire or transmit, who don't have a comorbid condition that puts them at risk for serious illness or dying, you know, you're not going where the need is greatest. And so I think this notion of equity versus speed is the wrong question. It is equity is good public health.
Yeah. You know, so you actually anticipated the question I was going to ask you, which is this, this framework that people have created. And it strikes me, it feels like what we've been doing throughout the whole pandemic, where it was, is it the economy or is it public health? And now is it speed, is it efficiency, or is it equity? And it has always struck me that those are the wrong frameworks for this, because you need both, and one actually begets the other, right? One begets the other.
And on that, I would also just say, I think we put too much focus on speed and are we getting it right? Of course, we weren't going to get it right perfectly, and this is going to improve as time goes on. But this is an imperfect science. It's an imperfect implementation world, and I think things will continue to move quicker and effectively if we keep those principles in mind.
Right. So one quick comment, then a question. I mean, the comment is, I think the work of the national academies, I think, has been profoundly influential in what ACIP ended up doing. So even if you didn't have all the facts and all the data at the time you were working, it got us thinking in a way that I think continues to reverberate and I think very much influence what's happening today. I guess one kind of follow-up question on this, and then I do want to sort of shift a little bit to thinking about global, because you're one of the few people who I think has done a remarkable job of being able to have a career that has been both at times deeply global and at times deeply domestic. And I love that, because I think we've often created that as another split. Are you a domestic person or a global person? Well, let me come back to that in a minute. One of the things I've wondered about is, so there are frameworks for how you want to implement. And then there's the reality that we are in a deeply inequitable society, that we're not in a society where if you set a set of rules, that everybody can navigate those rules equally. And then that some people are going to be able to navigate them differently. And I think about even, when we created testing sites, guess who got disproportionate number of tests in the early days? And it took a lot of time and effort to make sure that testing became available to a broader swath of our society, and particularly communities that were hit particularly hard. So how do you think about this issue of creating the right plan for implementation versus thinking about what is the reality on the ground going to be once that plan gets implemented? And should one shape the other, I guess, is almost my question.
Yeah, well, it's interesting. I mean, I think if we don't set for ourselves the goals that we want to accomplish, and we only say, well, this is the world as it is, not this is the world that we want to create, I don't think that we'll move the needle much. And so I think it's a bit of both. I think it is being very clear about what we want to address, how we want something like this, or anything that has a health disparities dimension. What are the things that we really want to accomplish? What are the goals? What are the targets? And one of the challenges that we know is that there's been lack of demographic data even linked to vaccination, so it makes it hard for us to be able to say, here's where we are and this is where we want to go. But I think unless we do that, we don't move the needle. That said, I think being realistic, primarily so that we don't get discouraged.
Yep.
I think there's a part of it that people feel like if we don't reach perfection, then it isn't worth fighting for. And I just think we've got to, set our bar where we want it to be, recognize that it's going to take time, and keep pushing on that. Because I think every time we push, we get a little bit closer to it. And we can get more into this when we talk about kind of my circular career. I think part of this is how do we knit things together? Because vaccinations don't occur in a vacuum. Health doesn't occur in a vacuum. And I think we don't always do the kind of job that we should to integrate these things, because we're not going to have greater equity in vaccines or health if we don't have greater equity in our society overall. So, I think it's a bit of push and pull.
I like that. I'm going to maybe use that. I know I was going to go global, but I want to ask one more question just on this, because it's something you were saying made me think of it. I think back to a year ago when this pandemic was just starting to get going, and things I said a year ago, Helene, I've gone back and done a lot of reflecting on things I said that I got wrong. And I'm going to share one of them. It's a little bit embarrassing in retrospect, and you're going to wonder, why are you having this conversation with me today? But I'll be honest and tell you, one of the things I said back last February was, I said COVID-19, or it wasn't called then that at that time, but I said, this is going to be the great equalizer. It's going to affect everybody. I'm a little embarrassed to admit that that's what I said, because obviously it was hardly the great equalizer. It was the great force that revealed all of the inequities we had and highlighted them and worsened them. But it took a while, at least for a lot of us in public health, to recognize that that's what was happening. So even though I got that wrong, the only saving grace, I wasn't the only one. And so part of what I want to ask you is, how did many of us get that initial framework wrong? And why do you think it took us as a society so long to figure out that this was having this very large disproportionate effect? And part of that is clearly data, right? We just weren't tracking the data on how this was playing out. But do you have any thoughts in reflecting on this pandemic and how it started and how it went? Why we were slow to recognize that, boy, this was anything but the great equalizer?
Yeah, and I think it's not exclusive to this. I think back to my years of HIV and AIDS, and that we said the same thing. HIV is an equal opportunity virus. Anyone can get HIV. And at the end of the day, we're right. All of these things are right. There is no virus that is specific to any particular biology or particular race, ethnic group, or what have you. It is equal opportunity, if you will, but what's not equal opportunity is our society. It's recognizing that. And I also think that there's a part of all of us that wants to think we're more egalitarian than we are. It's the creed of the American society. But I do think that COVID, George Floyd, all of these other things are kind of lifting our naivete about the society that we live in. And so I think we all are learning to lean into it, not to say, we're a bad people, but to recognize these things. Because again, I think until you recognize them, you can't grapple with them. So I just think that this has been a very interesting migration in thinking, if you will, as we all kind of come to grips with, every time we say that, we get proven wrong. So when are we going to recognize that that when we think about biologic agents and infections that can in fact infect all of us, why do we continue to have these patterns? And what's it mean about our overall society?
Yeah. Right. I like your notion of it's equal opportunity in biology, but not equal opportunity in the sociology and the broader social context. Right. And it is easy at times, especially as a medical doctor, and you'd think as a public health person, I'd be better at this. But even then, sometimes I get pulled aside in thinking about the biological and issues and the epidemiologic issues, but don't remember and can easily forget that the broader social context in which all of this lives. You brought up the HIV epidemic pandemic, and it has. I mean, we forget about it. It continues to kill people around the world, and we've made incredible progress. But it now, certainly when you look at where it affects America today, it's clearly in people who are otherwise disadvantaged. So it's not an equal opportunity virus. But you worked for quite a few years on thinking about HIV and worked on HIV/AIDS. And it's a different disease and different time frame and different timelines. But I wonder if there are lessons from your work in HIV/AIDS that help you see COVID-19 in a different way. And so I guess you mentioned the way on the issues around disparities, but I wonder if there are other lessons that you can think of or draw on from our 20 plus 30 years of work on HIV/AIDS as a community, in terms of what it should teach us about both acute management of COVID-19, but how we're going to have to deal with this virus over the longer run.
Well, I think, one, it does teach us that these things that are acute do become chronic, and we need to, if we really want to have the long-lasting impact, we can't think about these as short-term. I think it also continues to reinforce that we need to think about how do we keep our public health infrastructure strong, even when there's not a crisis. Because we would have been better with HIV, we would have been better with COVID, we would have been better with H1N1, with all of these things that we've seen recently, had we not let down our guard in between times. And while I don't like to use military metaphors, nobody would say, let's let the Army go home in between wars or in between, international concerns, et cetera. We keep them, we keep them equipped. We make sure that they are ready any moment. We don't do that with our public health workforce and our public health system. And, I just that's my hope, is that in between, we will one day think seriously about what does it take. And, and a lot of that is capacity, it's people, it's building, but it's also systems. Having, a surveillance system that has the best technology as well as the best people connected to it. It's having our laboratories, up to speed and, highest quality, et cetera. So I think, those are the kinds of things. I guess the other thing, and this relates some to what we're seeing now with vaccine hesitancy, particularly in communities of color, communities that have been most hard hit. Similar to HIV, it was so important that we worked with communities and that we listened to communities and that we recognize that, the best way that you talk about sensitive issues or scary issues is not by having, a national hero talk to people. It is by having local people. It's by having faith communities. It's by your barbers and your beauticians, or whoever it is that you feel understands you and is going to speak on your behalf and has your best interest in heart. So I think that lesson of how do we work with communities that are most impacted to find the message and the right messengers, I think is critically important too.
Yeah, great. I'm going to shift gears to more of the global scene in a second, but I do want to say for people who are listening, I could go for hours. Now, I promise I won't in asking Dr. Gayle questions, but I want to make sure that people have a chance to ask questions. So if you can put them into the chat, you can put them into the Q&A, and I will grab them out of there and ask Dr. Gayle. So if you have questions for Dr. Gayle, please send them along. I should have said that in the beginning, but I have a few more that I want to do before I want to give other people an opportunity. So we've talked a lot about inequities in distribution. We've talked about thinking about the strategy. I want you to put on this sort of broader global scholar and global expert that you are, and think about where this is going from a vaccine. Let's talk about vaccines for a second on a more of an international scale. I checked just before we got on, I checked the Bloomberg tracker. We've vaccinated about 154 million people around the world, or given 154 million doses. They're in about 10 countries. And they're not in the low-income countries of the world. And about 130 plus countries, not a single person's gotten a single dose of any vaccine. And so that's a problem, and we can spend quite a bit of time talking about why that's a problem, and it's a problem in many different ways. But how do you look at that? How do you think about that? And what should our response as the US, under a very different administration, and under administration that cares much more deeply about engaging in the world than the previous administration, what advice would you have to current political leadership? So both, how do you look at that set of data, and then what do we do about it, I guess?
Yeah, so one of our charges when we did the vaccine report for national academies was, in fact, to think about it globally. And while our main focus was how you allocation from the U.S., we also spent time talking about our global commitment, and we had a recommendation that, at that time we were in the process of pulling out of the WHO. We clearly recommended that the U.S. should re-engage with the WHO, re-engage with COVAX, which is the vaccine facility to pool vaccines for the rest of the world, and that we should put aside some amount. We suggested 10% that could be used for distribution in the rest of the world, and particularly in poorer parts of the world. And I think that those recommendations stand. For all the obvious reasons, this is a global pandemic. The virus got here because of global travel and international travel. We can't expect that we're going to bubble the United States, the United States in some kind of bubble that once we're fully vaccinated, that we're safe. So from a self-interest standpoint, we need to think about the rest of the world. But I think we also just need to think about it from all other types of standpoint. The United States has always been a leader in global health. We've been an important voice. We've been an important force. If our voice isn't there, I think it leaves a lot of potential for other voices that may not be thinking about, how do we look at this in a global and an equitable way. So I think it's critically important. The other that we thought about, again, back then, not knowing which vaccines were going to move forward is, well, suppose the first vaccine that was found to be highly effective was not one that we were involved in, and we've shut ourselves off. So, again, I think this sense of mutual collaboration and cooperation is so important. That said, I deeply fear that countries in Africa, Asia, and the Americas are going to be left out of this for much longer than I think is conscionable. And, these are places in the world that actually, because of the importance of vaccines, have systems in place that could deploy vaccines relatively easy. Now, I'm hoping that once the J&J vaccine, that's one shot that doesn't take all the kind of refrigeration requirements that the Pfizer, to a certain extent, Moderna takes, that it will be easier. But we've got to be committed to this, because I think it would be a shame for us, after all we've gone through, as much pain as we've seen, to not recognize that we have a responsibility to minimize that pain for the rest of the world.
Yeah. And one of the things, and I wonder if you could.
Oh,
no, go ahead.
I would just say, one of the greatest public health triumphs was PEPFAR.
Well, that's what I was going to go.
Okay.
I was going to ask you. I mean, it's been really remarkable. Has been how deeply bipartisan global health leadership has been in the United States, and the greatest public health, arguably the greatest public health success, certainly in the last 30 years, was led by President Bush, and continues to have phenomenal benefits. Are you optimistic when you look at today's landscape that we can have that kind of bipartisanship on global health leadership still?
I hope so. Throughout much of my career, we used to talk about global health diplomacy, because global health was the one issue that, no matter what the geopolitical dimensions of things were, people could come together. We worked with the Russians, we worked with the Chinese, we worked with the Iranians. This health and global health is a unifier. And I think it has, beyond just the health impact, it has all sorts of good benefits of how we can show that the global world can come together. So I'm hopeful that we may see something like a vaccine PEPFAR equivalent to make sure that we really do have a true campaign that can make a difference. And I also think that we always worry about, we're in the middle of a global economic crisis, but we also have seen that countries are willing to take out a lot of debt to be able to make sure that things work, and the world hasn't fallen apart. So I think we have room, if you will, even economically, to be able to think about how could we contribute to a global effort that means that in a couple of years from now, it won't just be the United States that's highly vaccinated, but we will also see countries around the world.
Yeah. Great. Thank you for that. I'm going to ask you just one more big-ish question, and I've got a couple of questions from students in the Q&A, so I'll get to those in a second. What I think is really striking, watching your career and watching you take on leadership roles, is where you've put some of that attention. So when I think about CARE, and when you became the CEO of CARE, there were multiple areas that you focus your organization on, and two that I want to just highlight, and then one of them comes up again with the Chicago Community Trust. Certainly seems like both at CARE and Chicago Community Trust focusing a lot on financial inclusion in care, the issues around wealth gap by race. That has come up as a recurring theme, and as I was thinking about that and reading about that, part of my brain goes, what's a doctor doing thinking so much about financial health and well-being? Can you, I think I know where you're going to go, but can you connect those dots for us? Help us all understand if you're focused on improving the well-being of people around the world or in Chicago or elsewhere, why has that been an area that you have focused your organizations on?
I guess the simple answer is kind of the social determinants of health. We know that access to health care makes a difference. It's kind of necessary, but not sufficient. But if we look at, what really makes the biggest impact on people's overall health and well-being, it's the non-health thing. And I think, for me, the journey, I started out as a pediatrician and realized that just by focusing on individual children, I could make a difference on those individual children's lives, or I could do public health and I could make a bigger difference. And I've always just kind of wanted to use the skills that I have to make the biggest difference for the most people. And if you start going, kind of, if you will, further upstream, it is the ability to feed your family, the ability to live in a safe neighborhood, have access to education. All of these issues are so core and fundamental, and they don't exist in our medical toolbox, but they are so critical to health outcomes for people individually, but also for communities. And so, I kind of traveled this road, and each job that I took kind of pushed me further into that. So, when I was working on HIV and realizing that at the end of the day, particularly in the global context, those who were most impacted were people who had to, particularly women as an example, trade sex for food. Core economics. It was not about, I want to put myself at risk. It was, I have I've got to survive. And I think these trade-offs that people have to make in their lives when they don't have the bare necessities, are so important to how we continue to improve the health of people's lives. So, for me, it was just continuing to dig deeper in terms of how do we attack the root causes.
Yeah.
We can keep working on the symptoms, and we need to. And we need to find doctors who hone their skills and take care of people. But we also need to be thinking about what are those root cause issues to begin with. So, I think that's how I got there.
Great. Let me pick up one last thing on this issue, which is, so one of the things that, again, talking about going upstream, often when people have asked me over the years, what's the most powerful global health intervention that we can make? To me, on one hand, the evidence and data on this is really clear, right? Which is educate girls and young women. And I don't mean the most powerful educational intervention. I mean literally the most powerful global health intervention. If all you care about is health, and we care about other things too, educating girls and young women is the most powerful, cost-effective, blah, blah, blah. It's terrific. And yet it has not happened nearly as widely, nearly as broadly as we want it to. And I wonder if you could talk about what you think are some of the barriers that continue to hold us back as a world on, if that is so clear, and I think it is pretty clear, and maybe you might disagree, but I think you're going to agree that it's pretty clear. What holds us back from making those investments and focusing on that as an intervention to improve social, financial, health, well-being?
Well, I guess, in a simplistic way, what holds us back is that it's hard. It's challenging to work with systems that have existed for a long time that don't work well for everyone. And it takes resources, but more than anything, I think it takes long-term commitment. And, we're often very short term in our thinking. It's a lot easier to do the things that are most proximate than the things that are further upstream, that take longer, that last beyond one's, whether it's their political lifespan or their organization's budget or what have you. And so I think it's in general these things that, take maybe decades to see the fruits of your labor are much more difficult for people to spend the time, the focus, and the attention on them. So they're hard, and they're also going up in many instances going up against cultural norms and traditions that may not value girls getting educated. And so, it takes time. I think about a lot of the work that we did when I was at CARE, working with some of the most remote villages in countries where girls getting educated was just not what you did. But again, it goes back to, some of the comments I made about HIV and community-based work. When you work with communities to start changing norms, you actually see things happen. But it takes time.
Yeah.
It's not something that people are often willing to do.
And it seems to me like as you were speaking, the two thoughts that came across in your remarks, which are really important, is on one hand, you have both organizational short-termism of if you have a CEO who's only going to be in for 5 years, or if you have a political leader who's in office for 5 years, there is a sense of, well, what can you demonstrate in that time period? And it makes it harder to think about what can I do that will benefit us at a time when I'm long gone, right? And the second is there are always other short-term pressing problems too. It's not like you're walking in and you only have this one long-term problem to deal with. There's a whole. So I guess I'm just going to ask you, so how do you galvanize momentum to overcome those two real problems of dealing with long-term issues?
Well, I think, by building on short-term successes. And, I think when you can develop approaches where you have a long-term goal, but you can measure it in short-term successes, I think you really do inspire and galvanize people to move forward. But I also think, I now am at a foundation and have been at a foundation before. I think partly how we fund is also problematic. Funders want short-term, want goals in 5 years for problems that are 20-year, 30-year problem. And anyone who's ever had to raise resources for an organization knows that if people could give you money unrestricted for 15 years, you could probably solve a lot of problems. But instead, we fund people in 2-year cycles, and we have these, strict guidelines of what you must accomplish by when. And big problems don't get solved that way.
Yeah, right. They're long in making. They're not going to be short in undoing, right?
Exactly. And when we developed our strategy at the Trust around closing the racial and ethnic wealth gap, we made it a 10-year strategy intentionally, not because we think we will have finished the work in 10 years, but if we didn't set something that was a longer-term framework, what people would be expecting was unrealistic. And so we wanted to have something that at least demonstrated we're in this for the long run. And, if we can, after a decade, demonstrate that we've made some progress, hopefully that will give people inspiration to continue further.
Great. Yeah. All right. I have a bunch more questions, but I'm going to stop because there are a bunch of students who have written in questions, and I'm going to stop being so selfish here. So the first one I'm going to ask is from Monica Zhang, who says, "Thank you for speaking with us," with a big exclamation. "As a student, I was wondering what you think are the most important aspects of your education that helped you foster empathy needed to treat patients and the understanding of what it takes to become a physician." So what are the most important aspects of your education that really helped you not just foster empathy for your patients? I'm going to broaden it a little bit. The work of your phenomenal career already has required really thinking with empathy and leading with empathy. And so what part of your education helped do that? What has accented that? And how do we do a better job of educators getting our students some of that?
Well, I think when I think back on, look at medical school as an example, we did a lot of work in community while I was in medical school. It was very important to get out. We would have hypertension drives or, other things where we would work with people in communities. And I just think that getting outside of the classroom and formal education is part of that. And staying connected to whatever it was that made you decide to do what you're doing to begin with. I think it's so important, and whether it's medicine or anything else, but you start on a journey for a reason. And sometimes we spend so much time preparing for it that we forgot why we started to begin with. So whatever it is that was your inspiration, remember that and go back to that and stay close to it. And again, for me, it was always doing things outside of just the educational arena and having the opportunities to broaden my own experience by taking on extra things. But that did give you a sense of the people who were coming in my door. What communities were they coming from?
Yeah.
What were the things that they were living with? And I think that helped a lot to build a sense of, what were the other things that I needed to be thinking about? What were the kinds of questions I should be asking people when they came in so that I actually understood their reality and their context better than I would have just by being taking the standard history and physical.
Right. I love that. So both constantly reminding yourself of what motivated you to get into this. But I love your line of stay close to it, because I think we can get pulled away from it. We come in with this and so having to be very deliberate about staying close to it. It won't happen naturally or automatically. So.
Yeah, and just one other thing on that, many people know Brian Stevenson, who did this great book, Just Mercy, and he has this phrase that everyone repeats about get proximal, and that was his whole thesis, that if you get close to the people who you're trying to make a difference in their lives, you will develop empathy because you see them as real people. You don't see them as a case. You don't see them as a patient. You see them as a whole person. So I think that notion of getting proximal is so staying proximal.
All right, I have a question from Ashley Gomez, who it's a really good question, and it's to you as now the CEO of the Chicago Community Trust. She asks, when addressing racial and ethnic inequities, I find that many funders require a high level of methodological rigor with short grant periods. So that sort of short grant time period issue, which is often not feasible if you're working with organizations who are resource constrained and may not be able to do that. And so she asked, how does the Chicago Community Trust engage with grantees to define measures of success, think about methodologic rigor, think about who the partners are going to be, and both have things that are rigorous and useful, but at the same time, be able to work across organizations that may not have that capacity or the resources to do it?
So great question. And I won't say that we do it perfectly, but some of the things we're trying to do, as I mentioned before, I think the fact that so often funders fund only for projects, not for capacity and not for organizations' infrastructure. It's hard to develop that capacity when you're constantly worrying about how are you satisfying your funders. So we went to doing a lot of our funding as general operating support. So the organizations had what they needed to build their organization. We've also put a lot of focus on capacity building so that we provide small community-based organizations support to be able to build their capacity. Capacity is always this word that's thrown around, but it's the ability to develop good budgets. It's the ability to develop a good website, the ability to develop, the skills for evaluation and measurement. And so, we spent a lot of time and resources making sure that small organizations have. And then I think the other thing we try to do is to take to decrease what we ask for to really what is necessary. So often funders ask for things. It really, collect a lot of data. Do we use it? Is it helpful? So what really is helpful to know about your effectiveness as an organization, whether you're accomplishing some of the things that, your resources were meant for, and reduce that to a bare minimum. We're also trying to work with other funders in the Chicago region so that we develop common metrics. Because that's the other thing, is if you've got 6 different funders and everybody's asking you for something else, all you're doing is meeting funders' needs and not doing your work. So we're also working on, can we develop a core set of metrics that we all use so that we're not overtaxing it. But again, I think this goes back to put yourself in the other person's shoes. And I am happy that I spent 10 years having to raise lots of money for a nonprofit when I ran CARE, because having only been a funder, either government or private philanthropy, you don't know the pressure and the burden that you're putting on people. So it was a good learning experience for me.
Yeah. Yeah, it's a super interesting thing, right? It's, having been on the other side, you have a much better appreciation for all of this and for what it takes to make investments for the long run. And this kind of coordinating across funders and foundations, I feel like I don't feel like there's been enough of that across. And so I'm thrilled to see it happening in Chicago. But I think that's a huge step forward in terms of moving away from organizations spending most of their time trying to meet the needs of funders and more of their time trying to meet the needs of the people they're trying to serve. Great. I have one more that actually, I'm going to go back to the questions here. Monica Zhang from earlier comes back with another question. You did such a good job on the first one. So she says, looking forward towards the future of medicine, what do you think are the most pressing issues within the medical community that are not being highlighted enough? And I guess, I mean, and you can expand this to public health if you'd like, but both as a physician and as a public health expert, when you look at what we're training our students in today and what they're coming out with, what are things that you think we need to be emphasizing more? What are things that we should be thinking about more if we're going to make them competent and effective, either as public health experts or as physicians, or both?
Yeah. So in terms of the actual pressing issues, I would just say I think we need to kind of be better at reading tea leaves and looking around the corner, because there are a lot of things. I mean, we all know that we could have predicted that COVID or something like COVID would have occurred. And so I think, there's just a core set of things that have to do with the fact that we are going to continue to have microbial threats, and we should be thinking about that, and we should be thinking about what do we need to detect, what are the most likely types of infectious agents, so that we are prepared. We all know that we were able to develop this vaccine so rapidly because of so much basic science research that was being done that allowed us to build on some of the platforms. So I think those clearly looking at that. And then I think, when it comes to the area of chronic diseases, again, I think we can predict if we, where are the areas where we could continue to make bigger difference. That aside, taking aside what are the diseases and what are the health conditions that we're going to continue to face, I think that we don't do enough and good enough job of giving people the other skills that will allow them to be better. So when I think about the other skills, there's a whole range of things in the information technology realm that, I think having people be more versed in whether it's AI and machine learning and all of these things that will revolutionize how we practice medicine, that I think are important. Clearly, the whole realm of economics and how economics and business and the private sector, we tend to wall ourselves off from the private sector, but it so influences so much of our world and so much of the issues, and it goes beyond just pharmaceutical. But I also think that things like communication, we don't teach physicians to be good communicators. We hide behind our jargon and we don't really think about what is it if the aim is to make sure that the person that you're with understands what you're trying to communicate, not that the aim is to sound as smart as you possibly can by using lots of big words. Um, how does that work? And I think, I mean, you're a prime example. You are an excellent communicator. And as a result of you being willing to put yourself out there in front of, millions of eyeballs, you move our field ahead. And I think so many people think about that aspect of communication as being dumbing things down or what have you. But at the end of the day, if we're only talking to ourselves and we're not getting these messages out, what good is it? So I think, those other skills that round that out, and I just think having the ability to keep learning about the way that the world is moving outside of medicine is an important, kind of envelope that I would love to see people learning more. I wish I had learned more about business and economics and, some of these other things, data future, because I think they're deeply important.
So it's great, a great answer. Thank you. And I just want to highlight what you've said, which is, if I think about, we talked about this earlier, the work you did at CARE, the work you're doing at CCT, and about touching all those things that have such a profound effect on health. And really thinking about what is the level of core competency we need of doctors and public health people in those. We don't need them to become financial experts. We don't need them to become AI experts, but they need to understand the basics of those things. I think on the communication thing is absolutely central. I mean, one of the huge problems in this pandemic, at least from my perspective, has been this almost communication warfare where there's been all this misinformation. And most doctors and nurses and public health people feel like they're not well equipped to engage in that in a way that's effective. But we need them. Like they're the people that people trust to drive that. Let me ask you one other question that's come up several different ways, and I'm just going to kind of summarize it. So this pandemic will end because all pandemics end. And it will get better. It's not that the virus is going to go away. We may deal with it for years, but the kind of acute phase. How do you empower people to think about a world post-COVID that is more equitable, that is healthier, better off, more prepared? How are you thinking about what are the things that we need to be doing now as we vaccinate, as we get the kind of global situation under control? Because whether it's this year or next, we'll be able to put a lot of this acute phase of the pandemic behind us. How do we come out of this, not trying to recreate 2019, but to create 2030, but ideally in 2021 or 22? What advice do you have for those of us as educators? What advice do you have for policy people? How are you thinking about that, Helene?
One thing, and it kind of goes back to the question before about skills, I do think students getting more involved in policy and advocacy is critically important. And I think we will change our world, not just because we programs differently or practice medicine differently, but that we actually change public policy. And, when I think about the things that we've been willing to do during this pandemic, that we said we'd never do, like give people checks. People have been talking about universal basic income for a long time and, with no traction. And now we're handing out checks to people because we know that if we don't, we're going to have a worse problem on our hands. So, I think there's a lot of things that we have learned from this, unemployment insurance for people who are gig workers, looking at increasing the minimum wage. And, there are a lot of these things that I think show that, in fact, equity and steps towards equity are possible. And so I just think, continuing to look at what did we do during the pandemic and what are some of those things that we could do differently. You know, the fact that cities are making an all out and out effort to go to communities to make sure that they do have access to vaccines. But we can keep those things going after the fact. Why stop just because everybody's vaccinated? So I think that there's so many things, and we were talking about it beforehand, you know, the fact that even living in this virtual world, we will probably never go back to being totally in person again. And it, you know, it erases a lot of barriers. So I think while we are living in this world where we are busting barriers all over the place, let's think about the ones that we want to bust permanently and make them happen.
I love that. And I'm going to just ask you to just expand on one part of that, and maybe we'll use that as a way to wrap up. So one of the things that's been very clear in this pandemic, and when we think about disparities, discrimination, the long-standing issues of systemic racism in our country and how that's played out, there are fundamental issues of trust and deep levels of distrust in the Black community for, I would argue, very, very good reasons in terms of how Black Americans have been treated by the healthcare system, by the public health system. And it struck me as you were saying, so now we're realizing that, oh, that distrust is going to manifest itself in vaccine hesitancy, for instance. And we got to go work on that trust. We're not just going to be able to tell people, hey, get vaccinated and it'll magically happen. But if we can begin to repair that trust, we shouldn't stop with the vaccines. So help me, if you don't mind, on two parts of that question, really. One is, how do we, in the short run, because there is an urgent need in the next months, certainly in the next year, what can we do to begin to address some of that mistrust now? And then how do we make sure that we don't walk away from it? Because there's a long history of, I mean, we often talk about with pandemics, the flipping between panic and neglect. I'm very worried about, we do all this, we go, my God, we got to work on these things. And then the pandemic comes to an end and we say, all right, back to business as usual. And we got to make sure we don't do that. So how do we keep working on that trust once we got beyond the vaccine? So how do we do it now? And then what do we do to sustain it, if you don't mind?
Yeah, I think now we, you know, working again with who are the messengers and what is the message. And, you know, the number of times that people have said, the fact that Dr. Corbett at NIH was one of the researchers who, you know, led to the vaccine has made a huge difference for people, because they say, she looks like me, she says it's okay, you know, it must be okay. And so I think building those kind of trusted messengers to carry a trusted message is important. And, you know, it's, I do a lot here with the churches and faith communities and other local grassroots organizations, because those are the people who have been there with these populations, you know, not just during crisis, but they're the ones who are there. And I just think, you know, that is so critical in this moment, that we have trusted messages, trusted messengers. I also think, though, you know, at a national level, we also need just a basic national campaign that levels the playing field, puts the facts out there so that there's an umbrella that people are working with. So I think we need to do it at the national level, but to really build that kind of trust, it's with people that already are trusted, is where I think. And you know, longer term, you know, and again, I'll use Dr. Corbett as an example. I think we've got to make sure that we have the right people at the table, because we all bring who we are to whatever situation we're in. And I will ask different questions because I'm an African American woman than my white male counterpart. Doesn't make him worse, doesn't make me better. It makes us different. And those perspectives, those different perspectives are incredibly important. And so I think if we really want to think about trust and equity, we also have to think about who's at the table, who are we training, who are we bringing in, so that, you know, we really do have that diversity of thought, that diversity of perspective that starts building that kind of trust long run.
Great. What a wonderful, wonderful note to end on. It is exactly noon in Chicago, 1 o'clock here in Providence. And Dr. Helene Gayle, it is hard for me to adequately express how grateful I am for you having taken the last hour. I learned a lot. I think everybody who was part of this did. So thank you for the last hour. Thank you for your leadership and really your entire career. I don't know how it's circular or not linear, but it's certainly been extremely impactful already. And so it really is very meaningful. And for all of you who are joining us for the School of Public Health, this is part of both the conversation series, and we've had some extraordinary people, and today was really just another highlight of that. It's also part of our Black History Month celebration, where we're working on a whole set of speakers and activities highlighting both accomplishments of Black Americans, but also making sure that we at the public health school are deeply engaged in addressing issues of health for Black Americans. So I want to just finish by again, thank you. This was real pleasure, and it was a lot of fun, to be perfectly honest. I really enjoyed it.
Thank you, and if I may, thank you. It was fun, really enjoyable. Thanks for all the great questions, but also just thank you for your leadership of this incredible school, but also your national leadership. It really does mean so much to have you bringing messages that are common sense that people can understand. It's a huge gift to the nation. So thank you so much.
Thank you. That's very kind. All right. Have a great day.